Okay.
Thank you, everyone. We're going to go on with our next session, and I'm just going to just pause for a moment and say that the previous session was incredibly interesting. I think we have a better sense of the spectrum of long COVID, and we begin to have some deeper insights. And I did like, there was one concept that I took away from the previous session, which is thinking about cancer and how we used to think of cancer as sort of one disease, and obviously now have much better tools to understand different types. And I think this idea that we can bring into long COVID to post-infection diseases, that we need to have better tools, and they may come from other fields. So moving to our session, we're really going to explore different aspects of the healthcare system. And Dr. Raju and I had a moment before at the beginning of the event today, and I think we acknowledged that it is so important to come together, for a day like today, and move away from our own specific focuses on different parts of the healthcare system, and really consider the either connectedness of all of that. So that's what we're going to try to do in this session. And I will introduce the speakers before each one of them has their turn. But we're going to start today with Dr. Leora Horwitz. She's the director of the Center of Healthcare Innovation and Delivery Science at NYU. We'll then move to Dr. Raju. She's the senior medical director at CIGNA. And then we'll have Dr. Moscicki, who's the chief medical officer of PhRMA, followed by Mr. Thomas Equels, who's the CEO of Immunotech. And then we'll close with Ms. Barbara Comerford, she's the founder of the law offices of Barbara Comerford, and she will be talking about legal aspects of disability. So I think all of the speakers, and this is going to be my really first true hybrid session. So I appreciate all the participants, and I can still see some faces on the screen, and at the same time I have three-dimensional figures next to me, so that's really exciting. Dr. Horwitz, we were hoping to see you in person. You're in New York, and we're in New York, but I understand that you're not able to join us. But let me just introduce Dr. Horwitz. She's the director of the Center for Healthcare Innovation and Delivery Science at NYU. She's also the director of the Division of Healthcare Delivery Science in the Department of Population Health at NYU School of Medicine. She's a tenured professor of population health and of medicine, and a practicing internist. Her work focuses on improving the safety and quality of healthcare delivery. And very important for our topic today, she is currently a co-PI of the Clinical Science Core for the NIH Recover Program to study post-acute sequelae of SARS-CoV-2. She also conducts the federally funded research on value in healthcare and has developed quality measures for the Centers of Medicare and Medicaid services. I always learn new things when I have to introduce speakers. And I was really delighted to know that Dr. Horwitz was named as emerging leader by the National Academy of Medicine and is an elected fellow of the American Society of Clinical Investigation. Dr. Horwitz, we're very pleased to have you today, really to introduce us to the clinical practice, and then also this important study that we call Recover, which is really the big NIH initiative to help all of us understand long COVID in a much better way. So, Dr. Horwitz, please.
Thank you. I'm so glad to be part of this, even though I can't be there in person. I ironically was diagnosed with COVID on Tuesday. So this is feeling very personal now. But here I am by Zoom instead. So I am, as Oved mentioned, going to split this talk into a little discussion of the potential impact of PASC or long COVID on the healthcare system. And then also I want to pivot and talk a little bit about recover because I think it is so important to know about. So can you just confirm that you can see these slides okay?
Yes.
Great, okay. So you have all talked repeatedly about what PASC or post-acute sequela of SARS-CoV-2 means. I won't spend a lot of time on it, but I do just want to briefly situate it from the perspective of the healthcare system, what we're talking about here. So remember that for physicians, we are thinking about people with PASC in a variety of different manifestations. And so we are dealing with people who have persistent injury from the initial infection. So people who lose their taste or smell from the initial viral effect on the nerves. People who have lung injury, either directly from the virus or from the inflammation caused by from the virus, or from the fact that we put them on ventilators and treated them and damaged their lungs, or from acute kidney failure from clots during the acute infection. There are many people who have really important and persistent long-acting organ damage from the initial infection that goes on, and we have to manage those over time. Then, of course, there's the people who seem to have maybe some kind of ongoing injury, perhaps, as you just heard a lot about in the last session, from either the initial infection or from an autoimmune response to that initial infection, or from reactivation of another virus because of the infection or whatever. And those are, of course, the ME/CFS or dysautonomia sorts of symptoms, and a variety of other things as well. And we have to manage those. And then there are people who, it turns out, are at higher risk of acute events. So myocarditis, inflammation of the heart lining, or heart attacks, or strokes, or new diabetes, or new kidney failure, that can happen in people who have their initial infection and recover and don't have any ongoing symptoms, but 6 months later suddenly have a heart attack. And although people have heart attacks all the time, there's good evidence now that that is more frequent in people who had and recovered from COVID. And all of these things influence or affect the healthcare system and how we're going to manage these over time. And sometimes people are thinking of long COVID as just these people with ongoing symptoms, but you know, the acute events matter too. And because I know that this community is extremely familiar with the first two categories here, I'm not going to spend any time on them, but I do just want to remind you that there's a lot of these other sudden event things happening too. There's a whole series of nice papers out of the VA system, the Veterans Affairs system, which is a useful system because people tend to get most of their care there, so it tends to be reasonably comprehensive. These are studies that involve around 150,000 people with COVID and around 5 million people without. They find that among people who survive COVID, starting 30 days after they have their COVID, they are at, in fact, increased risk of death, with about 8 extra deaths per 1,000 people by the time you get to 6 months. They're at higher risk of having stroke, about 50% increased risk of stroke, which is about 4 extra strokes per 1,000 people by the time you get to 6 months. They're at higher risk of this inflammation of the heart lining, myocarditis. They're at higher risk of heart attack. They're at higher risk of getting new diabetes. And all of these really can strain the healthcare system on top of dealing with the people who have ongoing symptoms. So just to kind of put that into context for you, CDC says there's 83 million cases. We know there's lots more than that, but at a minimum, let's pretend there's 83 million cases. About 25 million of those are people over 50 who are at risk of these sorts of acute events. We're talking about 100,000, 125,000 extra heart attacks, 100,000 extra strokes, 325,000 extra cases of diabetes. We only have 800,000 heart attacks and strokes in the country each year. This is a big increase for us. And the healthcare system right now is not really set up for managing all these additional events, plus managing the ongoing symptoms and the long COVID that we've been talking about. So I think that the direct impact on healthcare in this country over the next few years is likely to be profound, and we should really think about that up front. Obviously, there's going to be a high burden of these chronic fatigue, myalgic encephalitis, dysautonomia type syndromes. And that's a problem, as you know, because we already are pretty bad at that. We're not very good at diagnosing that. We have no idea really how to treat it effectively. And when I say we, I mean the average doctor. Obviously, there are centers of excellence and experts here and there around the country, but the average Joe doesn't really know how to manage these very well. And so we need to think about how to educate and how to really determine best methods of diagnosis and of treatment that we can get into the general healthcare community, not just at these sort of scattered places that have experts around the country. We're going to have a higher burden of cardiovascular and metabolic disease. We're going to have more frequent of these acute catastrophic events. And we're actually not sure why those are happening. And so we're not really sure whether our standard treatments are appropriate. So will the sort of standard therapies for prevention of heart attack and stroke work to prevent this kind of heart attack and stroke in long COVID? We don't know yet. We don't really know the cause. We don't know the right treatment. And as you'll see from this VA paper, the variety of things that people are using to treat symptoms of people who are having long COVID is all over the place, right? So this is just a list of the most common types of medications that are newly started for people after they have COVID. So presumably started to manage their symptoms. The numbers represent the hazard ratio, so the increased likelihood of getting one of these medicines compared to somebody who didn't have COVID. And obviously the most common you see here at the top is bronchodilator, so things to treat people who are wheezy like me right now. But we have non-opioid analgesics, so just generic pain medicines. We have anticoagulants. We have cough medicine for people with persistent cough. We've got a whole slew of muscle relaxants and anti-inflammatories and beta blockers for people who are having dysautonomia and anti-inflammatories. People just have no idea. And these are kind of blunt instrument treatments, and it's just not clear to us what we should be doing yet to manage. And so people are kind of throwing the kitchen sink at these conditions. We're also really not sure where we should be treating people with long COVID best. So, those of you who are suffering from post-exertional malaise and chronic fatigue, you can't go to the doctor all the time and go to 5 different specialists or 10 different specialists, right? That's exhausting. And yet we haven't really set up systems to make it practical and feasible for people to get good care. The fact that long COVID and PASC is so heterogeneous is also a problem because people have all kinds of different consequences and all kinds of different symptoms. It's really, part of the, we'll talk in a minute, part of the challenge about studying this condition is that it isn't a condition, it's so many different conditions. We have to ask about hundreds of different symptoms. And so there's lots of different experts who might be able or are appropriate to weigh in on how to treat these people. And that's not so easy to organize and make doable in an efficient fashion for patients. Long COVID clinics have been sort of proposed as the right answer here, but most of them really started as respiratory focused clinics in the early, sort of spring of 2020, because that's what we as doctors were most worried about, right? We thought COVID was a lung disease. We saw people having shortness of breath. We set up these lung clinics. It's not clear that they really have adequate expertise for the other sorts of symptoms and diseases that people are having. There aren't any standards, there's no guidelines, there's no certification for these clinics right now. And there's a lot of them. We know of at least 66, I'm sure there's many more in the US that have launched COVID-19 recovery programs. So I'm really just trying to situate the context here in which you understand that there is clearly going to be a new big burden of disease. We're not yet sure how to manage it. The average doctor doesn't know very much about this condition yet, and we don't understand it very well. And so, that I'm going to pivot now to how is Recover going to help with this, or what is Recover? So Recover stands for Researching COVID to Enhance Recovery, and it's the NIH's kind of umbrella program to learn about the long-term health effects of COVID. Right now, we're doing observational studies. We will move to clinical trials in the next few months. But right now, we're doing observational studies, which means that we're collecting information, in many cases, a lot of information, but we're not actually treating anybody in the study right now. Right now, what we're trying to understand is, can we figure out what is going on with people, and can we figure out what the right targets would be for treatments? So you all know this already. What is long COVID? Obviously, these are people who are having symptoms, and we think that there's many millions of people who are going to suffer from this over time. So the goal for the observational component of RECOVER is to understand what the trajectory looks like. So what does recovery from COVID look like? We have studies for adults, we have studies in kids, we have studies of pregnant people. We want to understand how many people are getting any kind of long COVID or past. We want to understand what the risks are for getting long COVID. So why do some people get it, some people not? We want to understand what the different subphenotypes of symptoms are that people get when they have long COVID. We want to understand why it happens, what is the biology of what's going on in the body with people who are having various sorts of symptoms. And we want to understand these acute events like heart disease and lung disease and so on. Ultimately, the observational studies will enroll up to 40,000 people. On the adult side, we have over 15,000 adults 18 and up that we will be enrolling, plus over 2,000 women who were pregnant at the time that they had COVID and their babies. And we'll be enrolling as well about 20,000 children and teenagers. The study is designed to match the population at large in the country who has had COVID. So we're being very attentive to enrolling racial, ethnic, rural, educational kind of demographics that match the sort of distribution of COVID in the country. And we also have autopsy component. So that's looking at people who have died after having had COVID. So we could again look at the biology. I run the adult side, so I'm just showing you our topics about the adults here. The important thing to note here is you can take part whether you've had COVID or not. We do want people who haven't had it, although they're harder to find because we need some controls. You can't participate if you're not in the adult side, if you're not an adult, if you are having a terminal disease, if you are in prison. And what we do is we have people fill out surveys every 3 months about their symptoms. At the beginning, we ask them about the symptoms they had before any COVID, so we can understand people with pre-existing conditions. And then after that, every 3 months for 4 years. And then we do some testing as well. So at least once a year and more often early on, we do a lot of blood tests. We do some basic physical examinations, including tests for dysautonomia. We do CAT scans and other things of the lungs. We do walking tests. We do physical function tests. We do a whole slew of things. We also collect a lot of biospecimens to reserve for future research that anybody can petition to use those samples for. So we are really trying to make sure that we have adequate samples for people to do all kinds of really sophisticated and new analyses, such as the sort of cytokine things that we were just hearing about. We're recruiting right now in 33 different states, plus Washington, D.C., plus Puerto Rico. And again, all 17,000 or so of the people who are enrolling on the adult side will have these basic labs and biospecimens and examinations. And then somewhere between 3,000 to 5,000 will go on to have additional testing, depending on their symptoms and depending on their trajectory. So we will have some additional tests that are pretty straightforward, like smell tests or walking tests, all the way to things like biopsies of tissue. So a whole variety of additional tests to make sure that we properly understand what's going on. You can go to the website and see where our sites are, and you could even volunteer to sign up. We have over 3,000 people already enrolled on the adult side, and we're moving along very quickly. So I'm going to stop there and look forward to your questions later.
Thank you very much, Dr. Horwitz. This was a great way to understand the magnitude of the challenge, and I think we'll save the questions until we have heard from the other speakers. And I'd like to introduce Dr. Nalini Raju. She's a senior medical director at CIGNA, and Dr. Raju really has a very, very interesting perspective because she is CIGNA's COVID medical director. She works closely with key matrix partners across the enterprise to coordinate CIGNA's COVID response. Her efforts have been focused on improving clinical outcomes and quality And these include ensuring that customers are supported and have access to vaccines, testing, and treatments. In addition, Dr. Raju has extensive experience with utilization management, coverage policy, and case management. And as I said, I always learn interesting things about speakers. So Dr. Raju actually completed her residency in general surgery and a fellowship in colon and rectal surgery at the University of Minnesota. So really very interesting way to get into understanding management of diseases. And she's also a graduate of CIGNA's Physician Leadership Development Program recently. So Dr. Raju, please. And would you like to use the photo or you prefer to?
I'm fine here.
All right, absolutely.
Well, thank you so much. I feel very grateful and privileged to be here. I was, as Dr. Amitay noted, we were speaking beforehand, and I feel especially with the overwhelming nature of post-COVID, we tend to get into silos trying to figure out our little piece. And this is just a wonderful opportunity to really understand what everybody's working on and find these common themes between the challenges that we are all facing. So today, my goal this morning is to try and answer 3 questions that hopefully you will find helpful. The first of which speaks to what you just mentioned, which is what are the unique capabilities that we at CIGNA have as a health insurer, and what insights can we offer on long COVID? The second question kind of looks back and says, and asks, throughout the pandemic, as an insurer, what have we been able to do to support our customers and ensure that they have the access to the right care at the right time and the right place? And especially with the constraints of the pandemic and quarantining, lots of challenges on that front. So what have we done, and what are we going to be doing going forward to ensure that people get the care that they need? And then lastly, which ties into that, is, going forward, what can we do to remove barriers and improve the quality of the care that our customers receive? So going back to that first question, which is what are our unique capabilities? At CIGNA, we really believe in the power of data as a tool to inform us and help guide decisions. So on that front, we have been following COVID related data before COVID even, before we even had reported cases in this country. But since then, what we've been doing is we have an analytics team that is very closely following COVID related claims. So we have amongst our customer base, so we have a COVID registry that has over 2 million customers. And by leveraging the data that we get from claims, as well as machine learning and advanced analytics, what we hope to do and what we're trying to do is to identify customers that need support and tie that into our existing case management systems, identify any trends that we can, and really try and make the connections between our customers, our clients, our employers, our brokers. So really share that knowledge so that we can offer our customers the resources that they deserve to get better. I would be remiss if I didn't say that we do have data. However, one of the greatest challenges with this data, and Oved and I talked a little bit about that, is coding. And there was a code, or there is a code that was released in October of 2021 for post-COVID conditions. Overall, what we're seeing is that the use of that code is increasing, but awareness in terms of how to use that code and when to use it is probably not where it should be, that we can use it to accurately identify all claims that are associated with post-COVID conditions. So from that standpoint, we're working very closely with providers to ensure that we share that information about how to appropriately code for conditions that are thought to be associated with COVID. So understanding those limitations, the data is as good as what's submitted to us. So we don't really have a denominator in terms of all our customers that are experiencing COVID-related conditions. If it's not submitted with that code, we have to try and get around that and figure out what are the other ways that we can identify customers who had COVID but are not recovering and they're still struggling within the system. So as I said, we have 2 million customers in our COVID registry. The majority of these customers do appear to have not experienced new health diagnoses. However, there is a subset that has. And what we did is to look at the time frame before their COVID diagnosis and then about 3 months after their COVID diagnosis and try and understand, are these customers developing new conditions? And what we have identified is, for the most part, the biggest uptick in conditions occurs within neurological conditions, behavioral health, and cardiac conditions. One of the challenges, though, is we get claims, but we get a large volume of claims that we don't, we get codes and we get diagnoses, but we don't have a lot of information beyond that. So we have to really be careful about attributing or understanding and attributing these conditions to COVID necessarily. It may be, and we think it is, for certain conditions like cardiac conditions, it's quite possible that the encounters with the healthcare system help to diagnose pre-existing conditions. But sorting that out is challenging, and it adds to the complexity of making interpretations of these new conditions that come to light. What we can say is that of that database of 2 million customers, less than 1% have had a claim submitted with this new post-COVID code. Again, that's a relatively new code, so we're about 7 months since the implementation of that code. Our hope is that as we continue to follow our claims data, that the use of this code will become more standardized and we'll be able to gather more insights. So moving on to the second question, which was, what have we been doing and what are we doing to support our customers that have complex care needs? We're concerned and have always been concerned about customers getting lost in the system. It is very confusing, and I think as we've learned up to this point, there's a lot of theories, and it can be quite confusing, especially when you know that you're experiencing, your symptoms are real, but imaging, lab tests, nothing is really producing an answer for you. So how can we help these individuals navigate the healthcare system? We have a very robust case management system. And in analyzing those interactions, what we've been able to identify is that for our customers that have been hospitalized with COVID and have a case management outreach after their discharge, they have a significantly improved rate of return to work, as well as a lower overall cost of care. And so what do our case managers do? Well, they outreach our customers, they help them understand the post-discharge plan, they can help coordinate these doctor visits. I think for a lot of these individuals, they may not have the necessary support from family and friends to even understand what they're being told to do, who they're being told to see. So just having that outreach is a powerful tool to help them navigate the system and then also return to work. In addition to supporting these customers with these complex medical needs, it's really come to light the powerful connection between mind and body. So I think the stresses of the pandemic have touched everybody, regardless of whether or not you have a diagnosed mental health condition. But it has been a tremendous strain on society. And from that standpoint, we've really worked on expanding our behavioral health network over the past 5 years. So of course, this predates COVID, but over the past 5 years, we've doubled the size of our provider networks. We have 800,000 in-network providers. And in addition to that, as within areas outside of behavioral health, we've also expanded virtual care. So at the beginning of the pandemic, less than 2% of our customers were utilizing their behavioral health benefits. That number has gone up to 25% now. Actually, I'm sorry, I misspoke. Less than 2% were of behavioral health visits were conducted on virtual platforms. During the height of that pandemic, that went up to 65%. It's now stabilized at 50%. So behavioral health and virtual modalities are here to stay. We noticed a 25% increase in utilization of the behavioral health benefit, which is really telling. 25% is a very significant number. So that combined, that number itself really emphasizes the need to ensure that everybody has access. And so with the large provider network and a significant expansion of behavioral health platforms, we're hoping that we can serve the needs of individuals of everybody, but especially those who have barriers to access and care. And that's another thing that's really come to light. Our data also confirm nationwide trends that admission rates, infection rates, and mortality rates were 3 times higher for African American and Hispanic customers compared with their white counterparts. So just tying it all in together, our focus going forward is really on ensuring that we continue to look at disparities, identify customers who have barriers to care, and think about how we can improve that. Looking forward, what are the areas that we really are placing emphasis on? One of that is ensuring that our providers continue to receive, and this is especially within the behavioral health space, the same reimbursement for in-person visits as they do for virtual visits. That's paramount for us. And then also we continue to advocate for prescribing via virtual platforms versus in-person platforms. And then lastly, as I mentioned, expanding our network of providers and partnerships with companies that can help deliver care virtually.
Great. Thank you very much, Dr. Raju. I think this is really giving us a very, very different perspective on trends and how we need to look at it from a macro perspective. So we'll get back to that. I'd like to introduce now Dr. Moscicki. Dr. Moscicki is the Executive Vice President of Science and Regulatory Advocacy and the Chief Medical Officer at the Pharmaceutical Research and Manufacturers of America, also known as PhRMA. Dr. Moscicki came to PhRMA in 2017 after serving as the Deputy Center Director for Science Operations for the U.S. Food and Drug Administration, also known as FDA. Center for Drug Evaluation and Research, CDER, since 2013. While at the FDA, Dr. Moscicki brought executive direction of center operations and leadership in overseeing development, implementation, and direction of CIDR's program. Previous to that, Dr. Moscicki was the Chief Medical Officer at Genzyme Corporation, where I had the privilege and honor to work with Dr. Moscicki. And I think it's important to note for today's discussion that he is also a board certified in internal medicine, diagnostic and laboratory immunology, and allergy and immunology, and actually maintained a long-standing clinic at MGH seeing patients. So Dr. Moscicki, please.
Thanks, Oved. And I appreciate the opportunity to come and speak and your invitation to do that, Oved. It's nice to see you.
In person.
We've known each other a long time in person, so it's really great. You know, as Oved asked me to speak about giving a perspective from the large pharmaceutical industry, I think we're extremely proud of what the pharmaceutical industry did for acute COVID. You know, from the beginning of the pandemic, companies worked day, night, weekends. There was unprecedented collaboration between companies and with the government at many different levels. With the NIH, of course, but with the CDC, with many, many others, to try and find the fastest ways for resolution and therapeutic and vaccine agents. So I was, you know, and then when I started to look at, so what about long COVID? And there's a bit of a different picture. After hundreds of clinical trials that were aimed at acute COVID and for the prevention of acute COVID with vaccines, there's a big difference. So I started by having my staff do a quick search of clinicaltrials.gov and to see what was going on, both in terms of all trials. And so we found about 141 clinical trials that are going on right now, at least listed in clinicaltrials.gov. But only 23 of those are sponsored by industry. And you can see the breakout here in terms of a few biologics, a few drugs, and a few even more few devices, and no combinations that were being studied by industry. And you know, this is such a contrast to the hundreds that we've seen before. And then, and of those trials that are by industry, they're really small companies. You're not seeing the Mercks and the Pfizer's at this moment, who played such a keen role in our attack on acute COVID. So I spent time then calling the heads of R&D to talk with them at many of our large pharmaceutical companies that are members of PhRMA, and also with their teams that are working on COVID, to find out what are they thinking, where are they going, what do they need? And it was almost a consistent picture from company to company of why they were at this moment still hesitating to go forward. The first thing that they all said was they don't understand what it is yet. We don't really know, at least, I mean, others might know, but I'll say we don't really know in the industry for sure what the pathophysiologic mechanism is in long COVID. Today, I heard some really interesting ideas about that from Dr. Patterson and others. And so, you know, I do think that there are many things, but before you get people to invest the millions of dollars that these clinical trials will need, of course, you need to have sort of more of a consensus set of ideas as you move forward. And one of the issues, of course, we've already talked about, I think we've heard it from some of the other speakers, that the symptoms overlap with other diseases, right? I mean, people who emerge from the ICU often do have a PTSD-like syndrome. Depression is not uncommon, period. It's not uncommon and is worse often after an acute illness. There are also, pulmonary sequelae that we've talked about too, that can complicate the situation. So, there's a list there of many of the other things that kind of all, like big Venn diagrams, kind of all bubble around this. And so the real sense that we have a need to really define what it is that we want to attack here and how to diagnose it. And so therefore a real need in the industry for a post-COVID-19 diagnostic test. And finally, when we do a clinical trial, what are the right endpoints? There are many different endpoints you could attack, but what are the ones that the regulatory agency is going to accept? And so really working together with the FDA and getting guidance from the FDA on relevant endpoints would be a critical factor to stimulate the attack from the large pharmaceutical companies. I think all of these could be addressed in some ways, and when they are, I'm confident that you will see the companies engage quickly if they know what the right agent that they should engage with is at the present time. I think it's already been mentioned by Dr. Patterson that obviously if you don't actually know what you're treating and you don't have a way to separate it from all of the other entities, your ability to actually discern a treatment response would be extremely difficult. So, and we've also just heard from Dr. Horwitz about RECOVER. And, I do think that studies like this from the NIH are going to be really, really critical in helping us start to separate this out, begin to look at things. What I heard this morning from Dr. Patterson on diagnostics, very important steps forward. And I think as we move together in collaborative spirit, I'm hoping that we can start to settle on what are the right diagnostic tests. And what is the pathophysiology? Therefore, what are the treatments? Are they anti-inflammatories? Are they immunostimulants? Are they antivirals? What is exactly the right best approach? And I think that we look very much to the NIH and the FDA for their guidance, I think, on these fronts. So with that, I'll stop. Pass it on.
Thank you very much. Thank you very much. And again, a very interesting perspective, the difference between the response to the acute COVID infection and the need to deal with the aftermath. So still a great need here. I'd like to next introduce Mr. Thomas Equels. Tom is the Chief Executive Officer of Immunotech. In February, since February 2016, Mr. Equels received his JD from the Florida State University and had a very successful legal career, which included extensive experience in the pharma sector. As I think, as we heard from Dr. Moscicki, there's greater involvement from smaller biotech companies right now, and certainly Mr. Equels represents one of them. But I told you that I'm going to mention one thing that I've learned about the speaker. So I also learned that Mr. Equels is a highly decorated combat aviator, and he was twice awarded the Distinguished Flying Cross and awarded the Purple Heart. So Mr. Equels, first of all, we thank you for your service, and we'd like to hear from you more about how you're addressing long COVID. And based on previous history. So Mr. Equels, please.
Thank you very much, Dr. Amitay, and thank you to the team at Global and Solve for your interest in Immunotech and our product Amplegin, which is the drug that we have. It's an experimental drug that we have been developing in part for ME/CFS and long COVID. I normally wouldn't tell war stories, but since you mentioned it, I'd like to point out that behind me is, and it's a print of a Picasso that is entitled Rest. And I have this in my office for a reason. And I think back to 50 years ago. This was the spring of 1972. I was a helicopter pilot in the Spring Offensive, which was one of the most hotly contested periods of combat during the Vietnam War. And I went perhaps 3 months without rest, and due to fear, anxiety, and other combat-related activities. So when I got involved working with patients who had ME/CFS, I could be empathetic and understanding what they're going through just from that experience I had. Of course, it was much more severe for them, and the fact that it was caused by something internal rather than external circumstances, you couldn't leave the scene and get a good night's sleep. So you know, I keep this here to help me remember that the work we're doing in ME/CFS and now that we're doing in long COVID is very personal and very important. We identified the relationship between ME/CFS and long COVID early on with the onset of COVID-19. And I'm not suggesting that they're identical. And in fact, the work that's being done by IncelDX is very much welcomed by AIM, because understanding the particulars from a diagnostic standpoint between the two, as well as the ability to track therapeutic response, becomes critical to drug development and successful movement on a path toward approval. And in fact, our work in ME/CFS, we're perhaps the only company that has developed a therapeutic that's been approved by any responsible regulatory agency in the world for ME/CFS. The Republic of Argentina granted our request for commercial approval for severe CFS. And we're, I believe, the only company that with the Amplegin that is late stage in the developmental process for ME/CFS in the United States. And the reason for that, I think, as was clearly pointed out by the preceding discussion, is that Big Pharma doesn't understand either of these diseases. So developing these diagnostic tools will become critical to have funding flow in and getting the approvals necessary for drug candidates that may provide an important and meaningful therapeutic response to both of these syndromes. Now, I mentioned that we were sensitive early on, and once we saw that COVID was moving into a pandemic phase, that we could be facing a post-COVID flood of chronic fatigue-like cases. Now, that was based upon a JAMA article and study that was conducted in a Hong Kong hospital after the first SARS epidemic. You may recall that back in 2002, 2003, there was an outbreak of SARS in China, Hong Kong, Indonesia. What was instructive there is that in those instances where survivors had the opportunity to report their condition, and then specifically the study was conducted at a Hong Kong hospital, approximately 27% of those survivors were reporting symptoms which met the CDC criteria for chronic fatigue syndrome. So that's a fact that I recalled, and when COVID came out, we analyzed the similarities between SARS-CoV-1, the original SARS virus, and SARS-CoV-2, the virus that is the virus that causes COVID-19. And in many respects, these viruses are identical and in the areas where they're not identical, very similar. So we anticipated that there might be a long COVID problem, and we began to secure patent protections for Amplegin as a therapeutic at that time. And then we moved forward to try and develop a plan. And again, we're very small. We're not a Pfizer or a Merck, but a plan that would allow us to determine whether or not the impact of Amplegin would have a positive therapeutic impact in long COVID. So if we could go to slide number 2, please. When looking at ME/CFS and as a part of our complete response letter with the FDA, we were asked at a meeting to examine where there might be in ME/CFS subsets that responded more robustly to Amplegin. And we looked specifically at time from onset of symptoms and saw a dramatic increase in response. There was a very significant response to Amplegin overall, but we saw an almost doubling of the response, positive response, when you looked at less than 8 years from the onset of the symptoms. Could we go to the next slide, please? Here's a graphic depiction of that, which you can study at your leisure, but it's a very dramatic impact when you look at shorter duration of symptoms. Now, why is that important for what we're discussing now? The reason it's important is because with COVID-19, for the first time perhaps, we have the ability to identify the cause of the chronic fatigue-like symptoms and measure where we are in the spectrum of time following acute disease for purposes of administering therapy early. Now, while I'm not suggesting that ME/CFS and long COVID are identical. And in fact, I think the InCell DX presentation suggests there are differences that are identifiable and important differences. There are also very distinct similarities. And with regard to those similarities, we focus on Amplegin's role, which we believe is amplifying the immune modulation response to help alleviate the disease. So we have an FDA authorized compassionate care, or what's called an early access type program in ME/CFS, and we were able to amend that to allow us to treat post-COVID chronic fatigue-like symptoms in the early stages of that disease. And we did this for a reason, because we felt it was important to utilize what effectively is a pilot study to give us some instruction as to whether or not Amplegin's impact in long COVID would be the same or perhaps even better than what we saw in ME/CFS. We've had 4 subjects, all of which had a very strong positive response in the areas of fatigue and post-exertional malaise. We also, have seen improvements in the cognitive dysfunction part of this disease. So that's led us to believe that we have a basis to go forward and seek an IND for a phase 2 type study in post-COVID conditions. So but specifically those conditions that we believe most relate to the subset that Amplegin addresses. One of the things, and I'm going back and forth between ME/CFS and our post-COVID work for a reason, because there are so many similarities. And one of the things that is an important similarity with the Amplegin responders in ME/CFS is almost uniformly those who responded to Amplegin related. Now, of course, this was anecdotal because remember, many of these people, it was years before their problem was even identified as ME/CFS. But an overwhelming number of these people were reporting that their problem commenced with a flu-like illness. So we think that there's a relationship between that initial, perhaps viral insult, that flu-like illness, and the subsequent events leading to fatigue, post-exertional malaise, sleep disorders, and cognitive dysfunctions. So
Tom, we have that 2-minute warning.
Okay, thank you. So we're moving forward as rapidly as possible. This preliminary work is being done at the Hunter Hopkins Center in Charlotte, North Carolina. We're providing Amplegin and the service to those subjects for free. And the data that we're gathering will be the basis for us moving forward. And I'm very excited about the work being done by IncellDX, and I hope to be able to have a one-on-one with them at some point in the future, Dr. Patterson, to see how their diagnostic and monitoring activities might help us better explain Amplegin's role in ME/CFS as well as long COVID. We've had great successes over the past 3 months with data coming out in our work in cancer, pancreatic cancer, advanced recurrent ovarian cancer, triple-negative breast cancer. And one of the points that was made by Dr. Patterson is absolutely true. Our work with cancer, where we're showing tremendous impacts on overall survival and progression-free survival, is not just measured by the survival, but they have the tools to explain why it's happening in immunological terms. We need those tools in this space as soon as possible for us to be successful in finding therapies that will alleviate the suffering of the many people. We're talking about millions of people who have the severe long COVID, and we want to help them along with others, but we need those diagnostic tools in order to do it, because otherwise I don't believe we're going to be able to progress with regulators or with big pharma participation and the money that flows from that.
Thank you very much. Very, very important comments. So we're going to move to the last speaker in this session, and I'm really honored to introduce Ms. Barbara Comerford, who's been practicing disability law in Bergen County, New Jersey, for over 30 years, and primarily in the area of ERISA long-term disability insurance and Social Security disability claims and litigation. She's one of the co-authors of the CFS Physician Manual, which was published jointly by the New Jersey Academy of Medicine, the New Jersey Department of Health and Senior Services, and has been utilized by physicians and patients throughout the country to recognize and properly diagnose CFS. Ms. Comerford has also co-authored professional journal articles on proving disability in ME/CFS, including for Frontiers and the journal Work. Also to note that she has been a member of nonprofit boards as well. Specifically for our discussion today, I wanted to mention that she's on the law line faculty. And since the fall of 2020, she's done seminars with them on a variety of topics associated with proving the long COVID-19 disability claims. In 2020, she also presented a seminar on proving the long COVID disability case for the New Jersey Bar Association. And she's been interviewed on this topic by many media outlets. So Ms. Comerford, I'm honored to have you with us today. Please, the virtual floor is yours. Oh, we can hear you. We can't hear you. Might be on mute. Press the space bar. Try.
Yeah.
Now we can hear you.
Yeah, I was trying to unmute, but the host wasn't letting me. So let me just say that I am honored that the GIC and the Solve Long COVID initiative invited me here today to speak, and I truly mean that. I mean, as you mentioned, I've spent quite a bit of time trying to educate lawyers, judges, and others on not only long COVID, but ME/CFS, which I have been involved, a movement I have been involved with for decades. And a dear friend of mine who served as the president of the Seafood Association of America, that's how far back I go. And I was the secretary of that organization. It was a nonprofit that's, worked to advocate for patients with CFS at the time, said it only took a global pandemic for people to start really taking post-viral illnesses seriously. So I am excited, and I learned quite a bit today listening to the medical professionals that preceded me and my colleagues who were attorneys and who now are part of PhRMA. I am relieved that I don't have to walk through the steps that I walk through when I present seminars for attorneys with what the common symptoms are with my long COVID clients or my ME/CFS clients. I am upset to say that we still in the legal community, and frankly, quite a bit in the courts, don't fully acknowledge that ME/CFS and long COVID are physical illnesses. I always kind of shudder when I hear behavioral health implications or neuropsychiatric implications in these cases, because for the longest time, particularly because of the incidence of these types of illnesses in females, in the 90s, it was called, hysteria to a certain extent. And it was very damaging for the people who suffered from these conditions to have to go and frankly be gaslit so often. So I am so thrilled to see so many well-educated scientists and physicians talking in this kind of forum about it. So thank you all. It's very heartening. The Social Security, my firm practices law all throughout the United States. So we litigate cases, not just in New Jersey, New York, and other areas. We litigate throughout the country. And one of the things that we have seen is the absence of objective documentation is really often fatal to the ERISA litigation. ERISA is the Employee Retirement Income Security Act. It is benefits, welfare benefits that are provided ordinarily by virtue of employment. So employers try to attract talent by offering them a percentage of their income in the event they become disabled. So clearly people, particularly young professionals, which is what we get, who we get calls from all the time with these illnesses, are really excited to know that they, God forbid, if the worst case scenario happens, they have a little cushion on the side, not just their 401k or savings. So we are here for individuals who become too sick to work and who, quite frankly, are having a rough time finding physicians.
I think we have a Zoom, a case
or
of Zoom
ME/CFS.
freeze. Oh, good. Barbara, I think we're losing you.
In global. Is it okay?
Yes, that now, yeah.
One of my clients who worked in global health, who was, a very young woman, was told by someone who held himself out as a long haul COVID practitioner that he was very friendly to her when she went there, but after she left, he wrote in the notes that he thought it was a psychiatric case. She had no history of psychiatric illness, and she worked in the most devastating third world countries and was, vaccinated for everything on the planet because she traveled so extensively. So my primary concern here is absolutely there's secondary issues that the pandemic has brought to light. But I think we need to be very careful and monitor our comments about assessing people with long COVID or ME/CFS as mental illness cases. And that happens more often than I like. But let me just spend a little time talking about how Social Security looks at these cases. And I have to compliment Social Security because my associates tell me, I don't do the Social Security cases directly anymore. I do most of the litigation, but my Social Security associates, all of whom have worked for me for a very long time, tell me that they have seen a lot of good things happening in long COVID cases that are before the Social Security Administration now. Now, Social Security passed an emergency message for COVID-based disability, which flags COVID cases. They don't flag it to do anything substantively to approve or not approve. They are just keeping track of the number of cases before them. That flag is just for the purpose of identification, tracking, and data collection. That is it. Also, Social Security it's funny because, listening to the sophisticated science today, Social Security seems very rudimentary. They will consider a case a long COVID case if there's a positive COVID-19 test, which of course for people who became very ill in the early stages of the pandemic is difficult. But fortunately, they also accept a COVID diagnosis consistent with the disease. And those are the telehealth appointments that people had early on in the pandemic. And Social Security, and where they received that diagnosis, and Social Security will accept that diagnosis. Also, diagnostic tests to support what they call a medically documented impairment, such as chest x-rays, cognitive testing, cardiopulmonary exercise testing, objective evidence of organ complications from COVID, and basically any medically accepted objective evidence of functional deficits that a physician believes are connected to the diagnosis of COVID are accepted. Social Security evaluates all of these cases all the same within the construct of a 5-step sequential evaluation process, where they ask, one, is the person engaged in substantial gainful activity? It is a term of art, but generally it means, do they suffer from such a severe functional limitation that they can't work? 2, is there a medically documented impairment that affects their ability to do basic work-related activities? As we all know, in these long COVID cases, it's not that the person is consistently the same day after day. What they generally have are, like CFS cases, good days and bad day presentation of symptoms. And when you have that, it's actually more maddening sometimes for people because they are very functional one day and then they suffer the post-exertional malaise crashes, just like ME/CFS people do. So that has to be documented as well. So I often tell my clients to diary things. At step 3, there is no long COVID impairment listing, just like there is no ME/CFS impairment listing, because Social Security has 14 impairment listing to indicate different bodily systems, and they want to know if this illness meets or equals a listed impairment. Quite frankly, most physicians that I've spoken to said, this is not even medical. This is like some kind of legal construct. So they're really not comfortable trying to fill in those blanks. So thank you. We don't have to satisfy step 3. We can go to step 4, which is, does this person suffer from such significant functional limitations that they can't perform the past work they performed in 15 years? And in most of the ME/CFS cases that we take, and the long COVID cases that we take, that's not a difficult barrier at all. And at step 5, the burden shifts to the Social Security Administration to show that despite these functional limitations, in line with the person's age, educational, and work experience, there are significant numbers of jobs in the national economy. In long COVID cases, just like ME/CFS cases, we generally approach those cases to document that they suffer from such non-exertional impairments, such as cognitive deficits, such as fatigue, such as post-exertional malaise, that they are removed from the very strict grid guidelines that ordinarily would place a person as not disabled under the Social Security regulations. So it's...
Barbara, I need to give you the 2-minute warning.
Okay, thank you. The last thing is the ERISA long-term disability claims are where we really encounter a lot of difficulty, because long-term disability insurers poo-poo the use of remote testing in neuropsych cases, which of course is crazy in the midst of a pandemic, so we have to fight them on that. They also go through the tilt table testing is not usually done these days, or not often. So we usually resort to recommending physicians use the Nalini test to document POTS and things that support the lightheadedness and dizziness component. And cardiopulmonary exercise testing is often something we urge for people to support the post-exertional malaise. And neuropsych testing, as I mentioned briefly, is crucial for so many of these young professionals who come to us, because it documents the cognitive impairment. And I must emphasize this, for people who are in the lower socioeconomic parts of our society, trying to get anyone to provide treatment for them that is really based on listening to them seriously is an imperative in this country. I'm so concerned about so many of my poor clients who come to me. We have lots of wealthy people. They're going to be okay. They can pay for these tests. It's my poor clients and people who are just looked at through a lens of, you just don't want to work. That really concerns me, and I can't emphasize the need for Centers for Excellence for those people, for long COVID cases and for ME/CFS cases, because those cases are hard enough to get doctors who are skilled, but they are really almost impossible in urban communities. So I thank you for giving me the opportunity today, and I hope I can answer any questions anyone may have. And by the way, anyone who has any questions, please feel free to contact me either via email, call my office. I'm always available to talk to people. Thank you.
Thank you very much. And we are short on time, but we'll take the privilege of just introducing a couple of questions with the request of short answers. But Dr. Horwitz, one question, and I'm going to consolidate a few questions that came for you. And the question is, we've heard a lot about a short window of time potentially to intervene, maybe because of changes in the immune system. how do you balance the sense of urgency and of course, the need to, this question has to do with the RECOVER study. How do you balance the urgency to study treatments with this rigorous study that takes so much time to start and finish? And is there a way, as we do that, to also be informed and include patients from other post-viral diseases such as ME, CFS, and POTS?
Okay, well, we are constantly on this tightrope of doing things at extraordinary speed for the sort of work that we're doing, and also trying to make sure that we maintain the best possible science and rigor. So, we enrolled our first participant in the observational part of RECOVER less than 5 months after we got the funding from the NIH to the Clinical Science Corps, which is, I think, the fastest anyone has ever stood up a study of this complexity and size and structure. So, we are doing as fast as we can, but we also, SARS-CoV-2 is here to stay. It's not going to go away. We're going to be having people with these infections for a long time to come. And I think that if in 5 years' time, we don't have the science that we wanted from RECOVER, I would consider that a real loss. If we, so we need to make sure that we are collecting the data that we need so that we can make sure that we get the right treatments and the right work. So we are constantly balancing this issue of speed versus doing it right. We are going to do interim analyses, all kinds of things to make sure that the public is aware of what we have before it's even final, because we think that's really important too.
Great, thank you. And obviously you hear the sense of urgency from the community. And also, I think in Dr. Moscicki's presentation, the industry is eager to get some of those insights. So that will be very important to share any interim analysis. One question to Dr. Raju, you talked about that in your database, you do see that there was a great disparity in how Blacks and Hispanics in the US were affected by acute COVID. Do you also have any data on long COVID and disparities in long COVID?
So the challenge, as I mentioned in long COVID, is identifying really beyond the codes, which of those individuals have long COVID. And so, and the volume of customers that have been that have claims submitted with those long COVID codes, it's like I said, less than 1%. It's really hard to draw conclusions based on that very limited data set. There are disparities that we have noticed amongst those customers with new conditions. And so really what we think is helpful is to align ourselves with partners within the community to try and get the information out there about new conditions and getting really the importance of follow-up care after COVID.
Thank you. Yeah, these data are really important. We don't have good data in the US about that, so it's going to be critical to get any insights on that. And I guess the last question is for Dr. Moscicki, and this is, I guess, drawing on your experience from the FDA. We talked about the need for, this is a complex a disease or a number of diseases. What do you see as the relevance of patient-reported outcomes as endpoints, and specifically issues of quality of life? Would the regulatory agency look at that as a possible endpoint for studies in these diseases?
I think the short answer is they would, as long as everybody agrees on which one and how it's measured and how it's validated. And I think there's a long history of this, these questions and trying to approve drugs based on them. But I think if it's done right, it certainly could be a basis for approval. Now, that's my opinion.
Thank you very much. So I see the cues from the organizers that we need to close this session. I really wanted to thank all of the speakers. This was really incredible overview of everything from the healthcare, different aspects of the healthcare system. So we will close this session and join in 5 minutes for the keynote presentation, which will be very exciting. Thank you very much.
It's my absolute pleasure to introduce our next speaker, who will be presenting on a white paper that is the product of Solve M.E. CFS initiative and the Solve Long COVID initiative. I have the pleasure to work with Melissa as a co-author on this paper, and I am so pleased at the results. This paper was a project due to a lot of requests for data, both from members of Congress and our public policy partners and from the community itself. So using mathematical models, as you'll hear, this paper strove to understand the prevalence and cost of long COVID. Melissa Smallwood is a science technology policy researcher with a background in neuroscience, psychology, social science, and disability studies. Her current work explores the long-term policy implications of long-haul COVID-19 and enduring consequences of the COVID-19 pandemic. Ms. Smallwood is working with the Solve M.E. research team, as you know, and is a co-author on this paper as well. Other projects that she has worked on include developing a role of the national laboratory system in the early pandemic response, the public assessment of human gene editing, and the future of healthcare. Melissa, are you with us? Oh, I think you're on mute. And we'll be sharing your presentation screen. There we go. Melissa, the virtual floor is yours.
Hey, hi, Emily. It wasn't allowing me to unmute until just.
Sorry about that. We got it all sorted. Thank you so much for joining us.
Thank you. And thank you for that introduction. So yes, as Emily said, Solve M.E. and the Solve Long COVID initiative recently put out a white paper estimating the number of long COVID cases in the United States, broken down by state, using publicly available data on the number of COVID cases that have occurred in the US. So the question that we had to answer in order to get these estimates is, how do we estimate the number of people who have long COVID, given that our public health authorities are really not doing anything to actually track these numbers? So in order to try and calculate an estimate, we needed to take the number of surviving COVID-19 cases times the chance of developing long COVID from infection. So when we conducted this study and made these models, the emerging consensus in the literature is that about 1 in 3 or 30% of people who are infected with COVID-19 go on to develop long COVID. And sometimes these numbers vary between studies based on what they're measuring, how they're recruiting, whether a disproportionate number of people in the study were hospitalized versus not hospitalized. But the emerging consensus, or about the average of these studies, is 30% risk, which is a lot higher than any other extremely widespread viral illness that we know of. So that by itself is very alarming. And then our study estimated that 1/3 of people who develop long COVID, or 10% of the total post-COVID population, will develop severe or life-limiting disability, such as that seen in ME/CFS from long COVID. And again, with some of the more recent research that's come out since this paper was published, those numbers as well could be even higher. But spoiler alert, as I'll be getting into, even the most conservative estimates of the number of people who are going to be affected by long COVID absolutely blow our disability system out of the water. So that brings me to the second part of our calculation for how many people have long COVID, which is how many people have had COVID-19. And that question is a lot more difficult to answer than you would think. Next slide. So we constructed two models in our white paper to try and estimate long COVID prevalence using two data sets that are released by the CDC about COVID prevalence numbers in the United States. The first one, which is our lower estimate, is based on reported cases. So these are cases that are reported by state health departments, hospitals, other health authorities. These are often PCR tests that are being run in the lab. And then those are reported up to the CDC and compiled into a total case count. The problem with these numbers is that we know throughout the pandemic this is an underestimate of how many people have had COVID-19. Due to the fact that from the earliest parts of the pandemic, testing has been inaccessible to a significant number of people who have COVID. Couple this with the fact that many cases of COVID are asymptomatic or present as a mild cold or mild cold. And people who may be having those symptoms may choose not to get tested, but just to ride out the illness at home. And then as we've seen, particularly during the Omicron surge, and what we're dealing with now is people testing at home using rapid antigen tests, which unfortunately in many cases are not reported to state and local health authorities and therefore not reported to the CDC and don't end up in the official case counts. So given that we know that these reported case numbers, as high as they may be sometimes, are an undercount, we used a secondary data set to try and account for some of these unreported cases. And that is using the seroprevalence numbers from the CDC's Community Seroprevalence Survey. So essentially what this is a project where community testing sites are set up around the country, and people have their blood tested for a specific kind of antibody that is specific to natural COVID-19 infection. So that allows them to differentiate between infection-related immunity and vaccine-induced immunity. And for each state, these the prevalence numbers of this antibody within the sample population are combined to create an estimate of the percentage of people in each state who have been infected with COVID-19. And this returns a much higher estimate. Throughout our study, it was about twice the number of estimated cases as the reported case model. So these two estimates combined create a range of estimated COVID-19 cases, in the US up to January 31st, 2022. Assuming that 30% of COVID cases will develop long COVID with a modified reduced risk that we accounted for breakthrough cases during the Omicron surge in December and January of 2022. Next slide. So just to go over the results of both of our models. In the reported case model, we estimated that 22 million Americans will be affected by long COVID using case numbers up to January 31st, 2022. And 7.3 million people will experience potentially severe disability from long COVID. This comes out to 6.9 or almost 7% of the population being affected by long COVID, and 2.3% of the full United States population potentially developing severe disability because of long COVID. Next slide. And then the seroprevalence model, which, as I stated before, gives us estimates about twice the number of COVID cases as the reported case model, estimates 43 million Americans, or 13.4% of the population, will develop long COVID, with 14.3 million, or 4.4% of the population, potentially being severely affected by this illness. Next slide. So given these prevalence numbers, we took, in our white paper, we kind of took a first crack at trying to estimate the financial burden that this widespread disability is causing on a state level. And in order to calculate this, we used data that had been collected by the COVID-19 Long Hauler Advocacy Project that looked at the personal healthcare costs and lost income being experienced by people who had become severely disabled by long COVID and were no longer able to work at their full capacity. About half of this population, they were out of the workforce altogether, reporting that they were completely or almost completely unable to work at their prior capacity. And the other half were operating at partial capacity and were employed in part-time work and had to reduce the amount of work they could do from full-time to part-time, with almost none of the participants being able to work at their full capacity. One thing that's important to note is that this data set assumed a 10% prevalence rate for long COVID from post-COVID patients, which is lower than the 30% that many more current studies are reporting, but is about on par with our estimate of 10% of COVID-19 survivors having disabling long COVID. And given the fact that these statistics did primarily represent people who are being severely affected by long COVID, we, in order to calculate the financial impact, we really used the statistics about the 10% of people being severely affected by long COVID instead of the 30%. So it's important to note that these numbers are also a drastic underestimate, since the full and long-term costs of long COVID on individuals, families, and communities, including from cases that might be less severe than full-blown ME/CFS, but still having downstream effects. All of that collectively is going to be much, much higher. Next slide. So the estimated costs of long COVID, which is just looking at the healthcare and lost income costs being accrued by individuals affected by long COVID, the reported case model numbers give a cost of $386 billion. And you can see on the map which states are most highly affected. There is a correlation with population for many of these models due to states with higher populations having higher numbers of people being affected by COVID and therefore long COVID. But our white paper does go into the percentage of the labor force in each state that is being affected, potentially being affected by long COVID.
Melissa, I'm gonna have to give you your 2-minute warning.
Okay, yeah, this next one's actually the last slide.
Beautiful.
Yep, and then our seroprevalence model gives an estimated personal cost of long COVID so far at $511 billion. And you can see from the map that the cumulative cost in each state is just gradually ticking up, with the states with the highest populations obviously bearing the highest cost, but really the cost of this is going to be felt in every state in the nation, and we are not right now in a position to deal with that.
Thank you so much, Melissa. Those numbers are positively staggering. Any final thoughts you'd like to share as we move on to our next panel?
I feel like I should say something brilliant. Not good at thinking of that off the top of my head on short notice.
No problem. Your work speaks for itself.
Thank you. Yeah, basically, the way in which we need to be acting on this needs to be coming from multiple angles. We need to view this not just as an individualized healthcare issue, but really as a more collective and community-based issue that is going to have ripple effects beyond the individual.
Hear, hear. I couldn't agree more. And hopefully the diverse expertise in this room and on this Zoom call will help contribute to that multi-angle approach to solving this global problem. Thank you so much, Melissa. I really appreciate your time. It's been an absolute pleasure working with you on this work. And all of you in the room, there's a handout that actually summarizes the white paper with a link on a QR code. And for those of you watching from home, the materials available in the room will be available after the conference along with the PowerPoint slides. So thank you all so much. Truly, truly fascinating work.